Hello everyone. My name is Dr. Rabia Sarwar. I am current PGY3 Internal Medicine resident. My co-authors are Dr. Mary Bavaro and Dr. Colin Delahousse. Together we are at Department of Internal Medicine and Department of Infectious Disease at Skagit Valley Hospital in Mount Vernon, Washington. I'm here to present today a case report of coccidioidomycosis in a young migrant patient with new onset type 1 diabetes mellitus. Coccidioidomycosis is a common fungal disease in the southwestern parts of United States, northern Mexico, and parts of South America, with the highest number of cases found in southern California and Arizona. The disseminated form of coccidioidomycosis is more common in African Americans, Hispanics, Filipinos, pregnant women, and immunocompromised patients. This case highlights the importance of early diagnosis of coccidioidomycosis in a non-endemic area such as Pacific Northwest. Diabetes is among other comorbid conditions that carries an increased risk of progression to disseminated coccidioidomycosis. So here we report a case of 29-year-old male patient who presented to the ED with complaint of 4 days of shortness of breath, fever, and chills. Exam findings were significant only for tachycardia and tachypnea. The chest X-ray, as you can see here, demonstrated a right lower lobe pulmonary infiltrate consistent with community-acquired pneumonia. So he was given one-time dose of intravenous ceftriaxone in the ED and was discharged home on oral antibiotics. Although he returned to the ED following day with progressive respiratory compromise requiring intubation and mechanical ventilation. At that time, he was placed on intravenous vancomycin and meropenem. All the infectious workup, including blood cultures, sputum cultures, and respiratory viral panel, including COVID-19, were negative. Urine, Legionella, and Streptococcus pneumonia antigens were also negative. We had a CT chest done, which was pertinent for bilateral lower lobe obesities. Patient underwent bronchoscopy with bronchoscopic alveolar lavage sampling, which grew coccidioidoms. Following that, a serum coccidioidomycosis complement fixation titer of 1x to 16 was obtained, which was concerning for disseminated disease. Meanwhile, the patient was also found to have skin finding concerning for disseminated disease, as you can see in this figure 1. The patient was treated with liposomal amphotericin B and high-dose intravenous fluconazole. The patient improved clinically and was able to wean off the ventilator after lengthy hospitalization. Once the patient was extubated, he actually reported that he was previously working as an agriculturist in Arizona and is now living in Washington state. Also, the patient during this admission was found to have newly diagnosed diabetes mellitus with a hemoglobin A1C of 11. Patient is being followed outpatient with our infectious disease department, and repeat imaging demonstrated gradual improvement. He remains on oral fluconazole with anticipated completion of 12 to 18-month course of antifungal therapy. So here we come to a discussion that most patients exposed to coccidioidomycosis are asymptomatic. Symptomatic patients often have symptoms which are not easily distinguishable from community-acquired pneumonia. For patients who are not responding to antibiotic therapy for community-acquired pneumonia and belong to non-endemic areas for coccidioidomycosis with positive risk factors or have a positive travel history of endemic areas should be investigated for coccidioidomycosis. As prompt initiation of treatments such as amphotericin B and azole antifungals can improve prognosis. Some cases may require surgical repairment and resection. The most common cause of dissemination of disease is underlying immunocompromised state. As discussed, 60% of infected people are asymptomatic at presentation, while 40% have mild symptoms such as cough, fever, fatigue, dyspnea, and non-specific joint pains. And this can make diagnosis challenging. So to conclude, we recommend that patients who fail to improve with conventional antibiotics for pneumonia and may have traveled through or lived in endemic areas should raise concern for coccidioidomycosis, as early diagnosis and management can not only decrease patient morbidity and mortality, hospital admissions, healthcare cost, but also the use of unnecessary empiric antibiotics. Thank you, everyone.